So just to put in a little bit of background for the international audience. So Ontario Health Teams are actually a product of policy change. That's the introduction of the Connecting Care Act of 2019, whereby different provider organizations were encouraged to collaborate together and provide to be fiscally and clinically responsible for their populations and the individuals within their populations. So since 2019, the government of the Ministry of Health of Ontario has actually approved 51 Ontario Health Teams in different waves. The first wave was 30, then 13, then 8 waves in 2021. So among these Ontario Health Teams, like they had different representatives of organizations or the communities they serve, actually created what you call some sort of like a group that would help to steer the organizations towards much more connected care. And this is what we call the leadership group. So we were interested to understand like what is actually happening in the field in terms of like the way collaborative governance is actually enacted. So we actually carried out 2 surveys, and we're trying to actually understand what are the main characteristics of this collective governance of Ontario Health Teams. And the survey specifically tried to capture the compositions of the different leadership groups and also how they perceived the way they functioned within their collaborative networks. So the first survey actually focused more on the composition of the Ontario of the leadership group of Ontario Health Teams. So in order to actually carry out the survey, we contacted like the evaluation lead of each Ontario Health Team. So we had 51 respondents that we asked questions about the size, changes in their leadership group or different governance models. So out of the 51 that we contacted, we just had 2 that we didn't include because one Ontario Health Team was still establishing its leadership group, and the other one gave us incomplete responses. The first results we actually saw was that there was some great variability in the size of leadership groups. The leadership groups actually range from 59 to 65 participants. Then we had like 1/3 of our leadership groups that had more than 20 members within the leadership group, and then there were like smaller leadership groups with about 5 to 9 members. Then the median was about 15 members per leadership group. Then we also noticed that there was kind of like a certain level of stability in terms of like the turnover of the leadership group. About 74% of our OHTs had like a turnover of 10% from since they were inducted. And then there was just 12% that actually had like up to a quarter to more than half of the leadership group that actually changed since they were implemented. Then we also wanted to actually understand how were these members chosen. So most of these members were really chosen to represent their initial signatory organizations, and also they were also chosen to represent specific health-related sectors like the acute care or the hospital or the primary care. Then very few, like just about 20% of OHT groups actually choose members to represent minority communities within the minority groups within their communities. So our key findings in terms of how the composition of these leadership groups was that they were relatively large. That is like most of them, with a median of 15 members going up to 65 members. Then there was also relatively stable, like more than 74% of them were actually had a turnover of 10%. Then most of them actually represented signatory organizations, with very few representing specific minority groups like indigenous, francophones or racialized groups. We actually now presenting about the how these groups were functioning. So what we did is we collected information from different members that could of the leadership groups, and we contacted about 1,423 in terms of like the survey distribution. Then about 387 people that actually were members of the leadership groups of their various OHTs responded. So our analysis was based on these 287 people. In terms of the distribution, some were present like in the primary care, that is like the primary care organizations, physician clinics, and the nursing clinics. Then there is the acute care, the hospitals, then the communities. So the very first, so the kinds of questions we wanted to understand is the decision-making processes that were involved, their level of commitments, how they actually monitored the implementation of the OHTs and their perceptions on the effectiveness of their Ontario health teams. So in terms of the decision-making approach, we noticed that about 81%, that's like basically most OHTs, they said that they made most decisions by consensus. So just like a minority were making decisions by membership votes. Regarding decision-making power, we also noticed that most respondents from hospitals, that is the acute care, they were more likely to think that decision-making, that all partners actually had equal influence in terms of decision-making, unlike the respondents from the primary care and the community organization that were more likely to think that some members within the leadership group actually had more power than others in terms of decision-making. So in terms of the perceived level of commitment, most acute care respondents, they actually were more likely to think that they were more committed, they were committed to the level of the decision-making of the organization as compared to the goals of their OHTs. Meanwhile, those in the primary care and community, they were more likely to think that they were more committed to their organizations than to achieving the goals of the OHTs. The perception on the effectiveness, we also noticed that acute care respondents, they were more likely to rate the effectiveness of their OHT as excellent or very good as compared to respondents from the primary care and community who were more likely to actually rate fair or poor performance of their OHTs. So in summary, we actually, what we noticed that most OHTs actually make decisions by consensus, and that most acute care respondents were more likely to actually think that every other person has that they were equal influence in the way decisions were made, and they also had more positive performance perceptions of the functioning of the OHTs in terms of like the level of commitment of themselves, how others were committed towards the OHT, and also in rating the overall effectiveness of the OHT.